Hello and welcome to this JCN Facebook Live seminar. My name is Alison Parnham and I'm a clinical nurse specialist for Nottingham City Care and a teaching associate for the University of Nottingham School of Health Sciences. It's really exciting to be delivering the first Facebook Live seminar of 2020. Today we're focusing on moisture-associated skin damage, looking at the structure and function of the skin and also understanding how MASD can be assessed, managed and prevented. This seminar is kindly supported by Medicare Plus, and at any time during the seminar you can submit a question by commenting on the video and we will do our very best to answer as many of your questions as possible. After the event, you can access your certificate of attendance, which will contribute towards your revalidation and CPD hours. We'll now move on to the presentation entitled Understanding Moisture-Associated Skin Damage. Before we do that, some acknowledgements. This presentation will draw information primarily from the following documents to support the evidence base around the content of this presentation. The learning objectives for the seminar are to revisit the structure and function of the skin, to describe the potential implications that excess of moisture can have on the skin, to explain how moisture-associated skin damage, known as MASD, the contemporary terminology, how that can occur. To outline the importance of the assessment and classification of MASD and to introduce the National Institute for Health and Care Excellence endorsed Skin Moisture Alerting Report tool as a smart resource. I will also explain how a structured approach can effectively manage problems associated with MASD. So firstly, the skin. As indeed the picture shows, where would we be without our skin? And it's important to think that the skin and its appendages are also known as the integumentary system. It's a complex system and it's also the largest and one of the most important organs of the body. It has a surface area of approximately 1.8 metres squared and it weighs around 4 kilograms, up to 20% of our total body weight. The skin receives 8 to 10% of total blood flow in an adult, and the skin's appearance and condition will always reflect our general health. So on closer inspection, we can see the outline of the structure of the skin. We can see the epidermis, the dermis and the subcutaneous, the three main layers of the skin structure. Within the epidermis is made up of a number of keratinocytes, which are epidermal cells. So those keratinocytes have a journey over a number of weeks. They germinate at the base layer known as the stratum basale. As they germinate and divide, they move up into a number of layers called the stratum spinosum. And as they're in the stratum spinosum, they start to change shape. They move from the stratum spinosum up into the stratum granulosum. And during this layer, those cells start to die through a process called apoptosis. And they move then up into the final layer, reaching the end of their journey over a number of weeks to the stratum corneum. The stratum corneum is made of 30 microscopic, closely packed layers of dead keratinocytes, which offer a buffering for our skin. The other thing to think about is that the epidermis is avascular. The epidermis regenerates through cell division on an ongoing basis, but it is in fact avascular. So it's totally reliant on its connecting membrane structure, connecting it to the dermis. So the dermis is responsible for feeding the epidermis through the capillary network. So if the epidermis and dermis were to be separated, which is what we're going to go on and talk about, the epidermis would not be able to survive that disconnection. So within the dermis, which is less than ½ centimetre thick, the epidermis is as thin as a piece of paper, so it just puts that into perspective. The dermis, around between 4 and 6 millimetres, is connective tissue and it houses a number of appendages. It's predominantly made of collagen fibres and elastin fibres. So within this connective structure, we can see the eccrine sweat gland. The eccrine sweat gland leads to a pore on the skin surface, and this has a role in the function of thermal regulation. The other sweat gland, which you can't see on this image, is the apocrine sweat gland. The apocrine sweat gland specifically attaches to hair follicles, another way of losing heat through the hair follicle. There are billions of free nerve endings all over the connective tissue, and this allows the constant ability for the skin to recognise signs of pain or discomfort. And in addition to that, as a sensory organ, the skin has sensory receptors, which are much more specialised receptors that allow the body to pick up the sensation of different types of pain or touch or tickle or pressure. The hair follicle, as you can see, sits as an appendage in the dermis, and the hair shaft is then the appendage in the epidermis. So the hair follicle has the sebaceous gland attached to the outer edge of the hair follicle. The sebaceous gland secretes sebum, again playing a function of the skin. Sebum is the natural oily substance that the skin produces through this method. The erector pili muscle also plays a role in thermoregulation, but is attached to the hair follicle. Okay, so let's move on to look at the functions of the skin. There are multiple functions of the skin. There are physiological, biological and chemical functions of the skin. The skin is constantly through those processes trying to sustain and maintain homeostasis. Homeostasis is the equilibrium between the body and the internal and the external environment. So let's look at some of those functions. The biggest function is protection. So it protects us in a number of ways. The first one is that it's a barrier to infection. So it's a physical barrier of intact skin across the skin surface. We produce skin flora. That skin flora is a milieu of controlled commensals that lie across the whole surface of our skin and plays a protective role against opportunistic bacteria that may be trying to get into the skin surface. And the control of that skin flora is also controlled by the sebum, which is slightly acidic, slightly waterproof, and provides that protective covering across the skin surface. The acid mantle, so it has an acidic mantle on the skin surface, which controls the skin flora, as I've said, and stops overmultiplication of our own body commensals. It's a barrier to insult. So we know that the epidermis is thick keratin from keratinocytes, and that gives us that barrier to insult. We know that our connective tissue contains collagen and elastin, so we have that strength, we have that elastability. And we have adipose tissue. So adipose tissue from adipocytes is fat, and it gives that protection against pressure, against insult. And as I've said, we have a number of sensory receptors which are constantly striving to alert our body against danger. Prevents damage from ultraviolet UV radiation. So it does that by the production of melanin. And it's the melanocyte cell that produces melanin. So the more melanin that's produced, the more protection we have. The less melanin that's produced by that individual, clearly the less protection we have from UV radiation. Prevents water loss as a skin function and promotes hydration. It's an absorption function, so the skin is able to absorb emollients for rehydration, lipid-soluble chemicals, medicinal patches, so fentanyl, for example, for pain control. The skin will absorb medicinal ointments and creams, steroids, for example, as an anti-inflammatory. And unfortunately for us, because the skin can absorb, it can also absorb more harmful chemical substances leading to harm of the skin surface. Synthesis of vitamin D. So this occurs in response to sunlight. So many hours per week required for this process. So vitamin D is metabolized from dehydrocholesterol, which is in the sebum and again sits on the skin surface. So once the vitamin D is formed, it plays a role in calcium absorption, encourages calcium absorption from the gut that we take through our diet, and they work in partnership for bone development and bone health. Thermoregulation. So if our body is too hot, so this is the equilibrium that the body is striving for. If our body is too hot, our blood vessels dilate, allowing warmth to be admitted through the surface of the skin, and the hair lies flatter across the surface as it relaxes and as the erector pili muscle relaxes. If our body is too cold and our core temperature drops, blood vessels constrict with little warmth then emitted to maintain a safe core temperature. The erector pili muscle contracts, and visibly we see, of course, across the skin surface are goosebumps. And finally, communication is a hugely important function of the skin. It allows us to express ourselves, it allows facial expression, it allows us to respond to the sensation of touch. It's about our physical appearance, it's about our physical individuality, and it's about our physical well-being. Our body secretes pheromones, which are communicative signals which may change behaviour. Okay, so let's move on to look at the impact of prolonged and continuous exposure of the skin to moisture. And there are two key factors that I want to start with. It's the loss of barrier and the loss of the protective function, therefore, of the skin. And that occurs as a result of overhydration of the skin, disrupting the barrier properties of the stratum corneum. So again, we're looking at the top layer of the epidermis. And this allows irritants to penetrate into the other layers of the epidermis. Once the skin is overhydrated, it's more prone as well to physical damage, including friction and shear. And what you can see from the image is maceration centrally and some surrounding redness, which may be likely to be due to friction or shear or a combination of both, or potentially pressure. But the white maceration in the middle is due to overhydration. The second key factor is the changes in the acid mantle. If our protective nature is to have that acidic balance on our skin surface, to keep our normal flora in that correct balance, then if that changes, the skin surface will change. So the pH of healthy skin is between 4 and 6. It provides an acidic environment that supports the resident commensal bacteria on the surface of the skin. So in overhydration, the pH of the skin increases, resulting in an alkaline environment that is then conducive to bacterial proliferation and infection and spread laterally across the skin surface. So we're going to move on now to look at moisture-associated skin damage. Moisture-associated skin damage is the umbrella for 4 clinical manifestations of this type of skin damage. And the difference between those 4 conditions is the type of moisture that induces skin damage. First one that we're going to talk about is incontinence-associated dermatitis. So incontinence-associated dermatitis is twofold. It has the urine side and it has the feces side, or it has the combination of both. So just urine sitting on the skin surface will cause overhydration. This in turn will potentially, although it's not always visible, cause some swelling of the stratum corneum as the urine is absorbed into the stratum corneum. This will cause maceration into the stratum corneum and laterally. Maceration leads to increased permeability. That, as I've said, can lead to increased friction. And once the urine is sitting on the skin over a period of time, the urea is converted to ammonia. Ammonia is alkaline, so the acidic mantle is lost and we move from an acid to an alkaline mantle. And this allows the flourishing of microorganisms, and they will thrive on the skin surface in this environment. With feces, lipolytic and proteolytic enzymes, as well as a high level of bacteria, sit in feces. So solid or liquid, those enzymes and bacteria are there. However, there are a higher number of enzymes in liquid feces. Enzymes act as damaging agents and they act on the urea to produce ammonia. So we start to see an even further increased pH. And the enzymes then become more active in a higher pH environment. So it's cyclical. It's a problematic cycle of events that needs to be eradicated. Combination of urine and faeces is therefore more harmful, and we can see that when we're assessing risk factors for the individual patient. So let's look at the clinical characteristics of incontinence-associated dermatitis, and we can see some of those characteristics on the images on this slide. So we're looking at widespread, diffuse, blotchy erythema. We're looking at very indistinct margins, and we're looking at the spreading of maceration. So what you can see in front of you on the top and the bottom slides are patches of denudement, so patches of epidermal stripping exposing dermal tissue, and what that comes across as and what we can see is partial thickness erosions on the skin surface. There may also be damage that is linear, which is more likely to be found in the skin folds. And we will start to see leakage of inflammatory serous exudate, which again further perpetuates the maceration on the skin surface. And we may see possible bleeding superficially on the skin surface as it starts to erode into the very surface of the dermis. Maybe over a bony prominence, in skin folds, in the anal cleft, or as perianal irritation with irregular shaped edges. So they're the key characteristics that make it very different from other types of tissue damage. IED can cause considerable pain, and I think sometimes this isn't always thought about in clinical practice because they're seen as superficial wounds, but they cause considerable pain, often burning and acute in nature, and untold suffering for the individual, especially, and this will be exacerbated following each episode of incontinence. And what we can see here on this skin structure is where the nerve endings lie. So the nerve endings lie just at the tip of the base of the epidermis. So if there's any level of epidermal exposure or epidermal stripping through moisture-associated skin damage, those nerve endings will be exposed to the environment, exposed to the air, and they will be hypersensitive because the nerve endings are still intact, but they are actually exposed. So that causes a high level of acute burning pain. So thinking about IED and pressure ulceration, skin damage that is established to be as a result of incontinence, so through your assessment, should not be recorded as a pressure ulcer, but it should be referred to as moisture-associated skin damage to distinguish it specifically, and it should be documented and reported separately. However, where there is necrotic tissue within the incontinence-associated damage, this will be due to a combination of both pressure and moisture damage, and that should be reported as a pressure ulcer. Okay, so let's move on under this umbrella of clinical manifestations. So we've looked at incontinence-associated dermatitis. So let's move on to intertriginous dermatitis. So what does that mean? Intertriginous dermatitis, also known as ITD, or maybe more commonly it's referred to as intertrigo. So this occurs when sweat is trapped in skin folds with minimal air circulation. So when the sweat cannot evaporate, the impact on the stratum corneum is that it becomes overly hydrated and macerated, and equally facilitates friction damage in the skin fold that is often mirrored in both sides of the fold. So you can see the axilla damage on the image on the slide, and it's mirrored on either side of the skin fold because of the movement of the arm and friction damage. So with IED, obese people are more at risk of ITD, due to excessive skin folds, increased perspiration to regulate body temperature, and higher skin surface pH, which makes the acid mantle less effective as a natural barrier. So this is intertriginous dermatitis. This damage in turn leads to inflammation and again a denudation of the skin, exposing the dermis, stripping off the epidermis, making the area much more prone to infection, either bacterial or fungal, but those commensals or microorganisms will be held within those skin folds, so much more likely to proliferate. It can sometimes be difficult to distinguish between IED and ITD in skin folds that are exposed to urine and faeces. So which is it? And I think very accurate assessment is fundamental to identifying a clear strategy to take this forward. So we've looked at IAD, we've looked at intertriginous dermatitis, and now we're going to move on to look at periwound moisture-associated dermatitis. And that is what it says, it's about moisture surrounding the wound. Remember that the production of exudate is a normal response during the inflammatory stage of wound healing. However, excessive volume of wound exudate can cause the periwound, and the definition of the periwound is within 4 centimetres of the wound edges. And that can cause the skin to become macerated. So it's the excess volume of wound exudate can cause maceration. And you can see from the image that we have a chronic wound with high levels of exudate with surrounding maceration to the wound edge. That will predispose to prolonged topical infection. So exudate from chronic wounds is known from a number of studies to be much more destructive than acute wound exudate. So chronic wound exudate is a harming agent. It contains increased levels of proteolytic enzymes called MMPs. So they're metallo matrix proteases. So our own body produces them, and the role is to break things down. But of course, when we have them in chronic wound exudate sitting against the skin, then they become destructive. They will interfere with the keratinocyte migration, and they will begin to corrode the skin. So the MMPs are harmful on the skin surface. And again, we can see from those images that we have excessive exudate on chronic wounds with a high amount of slough on the wound bed causing that exudate, and we have excessive leakage of exudate of those chronic wounds stuck in the inflammatory stage of healing, causing corrosive damage to the skin. And we also need to really consider the absorption and retention capacity of dressings if they are actually being used. So we need to aim for better control of that chronic wound exudate. So another factor affecting the occurrence of periwound maceration is a different type of damage to the skin, but it's caused by aggressive removal of adhesive wound dressings. And that affects the integrity of the skin barrier by stripping away parts of the dermis. And it will also create an inflammatory response as the epidermis is stripped away. So there's epidermal damage and the potential for continued maceration as that epidermal stripping causes leakage of inflammatory exudate. And you can see from the pictures or those images that we're looking at extremely friable skin where strong adhesives have inappropriately been used on that skin. Okay, so moving on to peristomal moisture-associated dermatitis. So this damage occurs when the surrounding skin encounters effluent from the stoma. This may occur soon after the initial surgery and then reduce as the individual becomes more competent at caring for the stoma. Alternatively, it can also develop later as the body shape changes, way down the line post-operatively. So management depends upon the correct choice and application of the containment device in addition to a clearly structured skincare routine. Okay, let's move on to think about some of the management strategies. What can we do to reverse some of the damage that you have seen and prevent it from returning? And I think the key, the most important, is to optimise prevention and management. So it incorporates both of those fundamental aspects of skincare. So the approach to care will be similar in the first instance for all 4 types of moisture-associated skin damage. And it must focus on a thorough assessment of the patient and their skin, and, where appropriate, exclude pressure as a possible cause. So you're looking at this very specific cause of the moisture-associated skin damage. Identify the underlying cause, determine and classify the extent of damage that has been caused on the skin surface as part of that assessment. Manage excessive moisture. So it's about how can we control this excessive moisture. Implement a structured skincare regime, fundamental to optimising prevention and management. Using products to effectively treat the moisture damage and continue to protect the skin. Treat any secondary infection. Know what a fungal spread or a bacterial spread may look like on the skin surface. Should we be swabbing that level of damage, and look at antimicrobials, antifungals that are topical on the skin for that short duration of the presence of infection, and then look further down the line at continued prevention and management. So the classification and management, or the classification within that assessment process, there is evidence that does offer some classification, but the evidence out there is very limited. There is a resource that does utilise numbers and letters to categorise the extent of skin damage. However, remember that it is only specific to one type of moisture-associated skin damage, which is incontinence-associated skin damage. So whilst that it has a value in clinical practice, it doesn't incorporate the 4 categories that we now understand to fit under the umbrella of MASD. And that particular resource is, because it uses numbers and letters, it's actually really quite similar to the European Pressure Ulcer Advisory Panel, and that actually could lead to some confusion in clinical practice. So what's the answer? There is a new resource that would help us to classify and manage moisture-associated skin damage in clinical practice. This is the Skin Moisture Alerts reporting tool, and as a valuable resource it summarises all 4 types of MASD that I've already talked about, and it classifies the extent of damage as mild, moderate and severe. It's much easier to use in clinical practice, and we're not involving numbers and letters, so it's much more straightforward. And this resource also offers a general management plan. So it's endorsed by NICE, it's very recently been endorsed by NICE, and I think that's very exciting. It's a resource that supports implementation of recommendations in the NICE guidelines on pressure ulcer prevention, urinary incontinence and fecal incontinence. So it supports the clinical guidelines and the nursing guidelines that we already have in clinical practice. So let's look at the extent of damage then. Let's focus for a minute on the skin damage meter, which is part of the SMART resource to use in our everyday clinical practice. So what's the definition of mild? So mild, coming back to this word erythema or erythematous, it means it's redness on the skin only, so there's no break at this point. It's dry, it's intact. Intact doesn't mean not damaged, but intact does mean unbroken. The skin is irritated, and at this point it's very high risk of further breakdown if the cause isn't removed. So moving into the moderate extent of damage, we're looking at perhaps a wider spread of erythema, but with less than 50% of broken damaged skin within that spread of redness. We may see some oozing of inflammatory exudate, so we may get further problems with maceration, and we may see surface bleeding or superficial bleeding if the tip of the dermis is eroded and those blood vessels are damaged. So moving into the more severe extent of tissue damage, we're looking at a much larger area of very erythematous. You can see that it's much redder, it's much more inflamed, and it's more than 50% of that red area that is then damaged. So it's about the amount of skin that's damaged within that redness. We are highly likely to see a greater amount of inflammatory exudate. There'll be more exposure to nerve endings to the skin surface, so a higher level of pain, and we may also see bleeding at this level of damage. So I think the skin damage meter is a very quick and easy way, and also for reporting methods, to identify, am I looking at mild, moderate or severe damage. So moving into some of the management strategies then, we need to be looking at skin cleansing. How are we cleansing patients' skin when they have the beginning of moisture-associated damage? How are we cleansing it to prevent moisture-associated skin damage? And I think you'll agree that in current practice, the most common method of cleansing the skin is with soap. It's what we're used to, with warm water, with a flannel or a soft wipe, and a towel to dry. I think we need to think about the implications of this on patients who are suffering with moisture risk on their skin. So traditional soaps. Traditional soaps are alkaline, they may smell nice, but they can disturb the acid mantle. Those increased pH damages the skin barrier, or that increased pH will damage without a doubt the skin barrier. Frequent washes will also decrease the natural sebum, which allows the opportunistic bacteria to then flourish and multiply. Sebum has acidic properties, so frequent washing will wash away that natural protective skin surface. Soaps are perfumed, and that perfume with the content of alcohol may cause irritation on the skin surface. So what can we do? We can look at alternatives to traditional soaps. Using a non-scented, mild, pH-balanced soap, a pH of 5.5, with dry, disposable wipes and water. We should be avoiding cleansers with alcohol and preservatives. Preservatives can cause irritation. So consider an emollient as a soap substitute is another alternative to the traditional soap, but always pat dry. There's no benefit to rubbing the skin dry. It's a myth that that somehow stimulates the skin. It will damage the very fine, fragile capillaries at the skin surface. So pat skin dry. The other alternative is a foam and spray cleanser, because it's pH balanced, it's preservative and alcohol free, no pain, no rinse, moisturising cleanser that is suitable for use on moderate to severely damaged skin from moisture associated skin damage. It can be used in a foam mode or the spray mode depending on the area of use and how widespread that damage is. So it's for ease of application. So provide an effective barrier against moisture. Also avoid the traditional barrier creams. They contain perfume, therefore they contain alcohol, therefore they will cause pain. They contain preservatives, so they can cause irritation. And they are highly likely to interfere with pad absorbency. They create a protective barrier on the pad which stops the urine from then getting into the pad, which then means that the urine will have to be somewhere else on the skin, causing moisture-associated skin damage. Modern barrier creams are very different. They protect intact skin or mild skin damage for up to 3 washes. So it's an economical way of managing the integrity and maintaining the integrity of skin. They are alcohol and preservative free. They contain silicone, so that's a clear water repellent. Remember that skin should be completely dry before the application of the modern barrier creams. And we certainly should ensure that the skin is dry after the barrier cream has been applied before we then apply the dressings. The modern barrier creams do not affect pad absorbency, and they can very effectively prevent periwound maceration and medical stripping through medical adhesive products. Barrier films, alcohol-free and non-sting in the same way that the modern barrier creams are. They're indicated for mild to moderate skin damage. They're preservative-free. They do not affect pad absorbency if they're being used in the clinical situation for IAD. And the films will last for up to 72 hours. So again, an economical option for maintaining skin integrity. They can prevent periwound maceration and medical advice related skin injury, which is MARSI. So in summary of MASD, remember that MASD, don't get confused, but remember that MASD is the collective term for the very specific 4 types of moisture damage to the skin that I've already discussed. This damage is caused by chemical irritants, proteolytic and lipolytic enzymes, or because of an alteration in the skin pH, all of which can contribute to the destruction of the skin's barrier function and be further complicated by the potential for bacterial and fungal infections. The takeaway message for this seminar is a focused intervention approach will be required based on your knowledge and your understanding of the underlying causes of MASD. A structured skincare routine that involves cleansing, protecting and restoring damaged skin will help with the prevention and management moving forward. But always remember, you are still working within your local guidance. This smart resource is also available in a convenient card, which I'm wearing, which I shall show you. Okay. And if you want to access this card as a free resource, you can access this through the website address through Medicare Plus. So it's something that can be conveniently worn and easily accessed for the information that I've discussed. Okay, thank you for listening so far. We'll now move on to our real-time question and answer session. Remember, you can take part at any time by posting your questions on the video. Okay, and our first question, oh hi Alison, is from Alison Schofield. How do you tell the difference in moisture-associated skin damage from pressure ulcers? An excellent question, and there is lots of information out there in the literature that offer clear guidance around the difference of moisture-associated damage and pressure ulcers. So I've described the classification of moisture-associated damage and the fact that we're talking about diffuse, widespread erythema or erythematous regions. Pressure ulcers are more localised to where the pressure is being applied, so they're rounder in nature, they're less diffuse, they're likely to be far deeper than MASD if they're going to full thickness category 3 or category 4 pressure damage. And a pressure ulcer will only happen as a result of pressure being applied to that local area of bony prominence. So we're much more likely to be able to differentiate by the clinical difference of an MASD and its spreading erythematous, diffuse, more superficial areas across the skin, damaging the epidermis, visibly seeing the dermis, whereas pressure ulcers will be rounder, more local. They may contain necrotic tissue, which an MASD doesn't, so they're more likely to contain slough or eschar, which you wouldn't see present in an MASD. And question 2 from Maddie Rylance. Hi, no such thing as a daft question. Are IADs the same as moisture lesions? And I think what this presentation has tried to clarify, or hopefully clarifies, is that we use incontinence associated dermatitis now that falls into the umbrella of the contemporary term of moisture associated skin damage. Moisture lesions are really the same as IAD, but moisture lesions doesn't specify the underlying cause. So moisture lesions really could be considered more to be the umbrella term for MASD. So IAD, just to clarify, is one type of moisture associated damage or moisture lesions, but it's not a daft question. Okay, and question 3 from Ailsa Greenwood. Is this going to be painful, or will nerve cells be damaged? The nerve endings can be damaged with continued erosion. So I'm thinking that you mean, is this type of damage painful? Yes, this type of damage is particularly painful once we get the moderate and severe type of MASD. So we get the denuding, the stripping of the epidermis, which means that the nerve endings are exposed to the air. They're not damaged as nerve endings, they're hypersensitive, so they cause this acute burning pain on the skin surface. And covering those nerve endings with the barrier creams, with the barrier films, will hugely reduce that pain because we're bathing the nerve endings in that product. And question 4 is from Emily Bourne. Is combination skin damage only when necrotic tissue is involved, or can it be slough? Okay, so a combination ulcer or combination skin damage is when it involves both moisture associated skin damage, so potentially we're looking at IAD here as an example of MASD, and pressure. So it's a combination of IAD and pressure. So pressure is the cause, you can, as well as IAD. So we're looking at both IAD, so caused by urine or feces, and also pressure damage. So if you're seeing necrotic tissue and slough in amongst IAD or another type of moisture associated damage, then it is a combination. So what we won't see in moisture associated damage on its own is the presence of dead tissue such as eschar or slough. And question 5, Judith Ralethicol, mild is classed as category 1 then. Category 1 is associated with pressure damage, which is why we want to avoid the use of numbers when we're looking at moisture-associated skin damage. So mild is a mild severity in this scale, in the severity scale. We've got mild, moderate and severe. So mild sits at the beginning of that classification, but it's associated with moisture-associated skin damage particularly. Category 1 is only associated with category 1 pressure damage. So if you're seeing a patch of redness on the skin and it's in the region of the sacrum or the buttocks or the perineum, you need to identify from your detailed assessment what is the underlying cause. Is the underlying cause moisture or is the underlying cause pressure? And it could be from your assessments that yes, the underlying cause may be moisture, but actually that equally puts the patient at risk and at higher risk of pressure damage. So you may find that looking at that vulnerable individual, you're looking at prevention of moisture, but also you're looking at the prevention of pressure damage. So mild is not classified as category 1. Mild is associated with moisture-associated damage. Category 1 is associated with pressure damage. And question 6 from Emily Bourne, is aqueous an appropriate emollient? A lot of patients like it, but I've heard it doesn't have much effect. Aqueous is a very mild moisturiser. It's not an effective cleanser. So we've talked about cleansers rather than emollients. So my answer would be it's not an effective cleanser and it's a fairly weak emollient. It's not greasy enough to be a good emollient and it doesn't get enough lather up to actually make it a good soap. Question 7 from Janet Mason Rawle. Thank you for your question. Should we be placing dressings on moisture damage? A very good question. It depends on the severity of the damage. If we're looking at mild and moderate, we're really looking at topical applications. And if they're widespread, we're looking at topical applications of creams or films. I don't mean film dressings, I mean film sprays, because we're looking at covering that much wider area of erythematous erosion. If there is an area, and it's likely to be a smaller area, that is perhaps bleeding, then yes, where it's appropriate to put a dressing on that, what you want to continue to do is to stop the entry of infection. So we're looking at the widespread use for those diffuse erythematous areas of irritation to soothe it with the cream or film application. But if there is a smaller area, we can use that, allow it to dry on the skin surface, and then apply the appropriate dressing to that damaged area. Okay, and the final question, question 8. Can we obtain more cards to give to the rest of the team? Absolutely. If you go onto the Medicare website, you can get as many cards, I believe, as you request. This concludes our live training session. Thank you all for watching and thank you really for sending in your questions. So I'd like to take this opportunity to thank Medicare Plus and Dale Copson, Clinical Services Manager, for their support of this event, and with particular thanks to Sharon Jones and Claire Winterbottom, Clinical Nurse Advisors, for developing this excellent smart resource for use in clinical practice. To access your certificate of attendance, follow the link shown on the screen, or alternatively, it will be posted on the comments section of this video. And finally, I hope that this has helped you gain a better understanding of moisture-associated skin damage.